All right, good morning again. And for those of us joining us from across the pond in Nigeria, good afternoon. And welcome everybody to a current concepts lecture being hosted by Operation Stand, Walk, Run. This is the second lecture in our series, and we're excited to present a cutting-edge sports medicine topic for you all today. My name is Degenerative. Like I mentioned, I'm an orthopedic surgeon practicing in Illinois, focusing adult reconstruction. One of the founders is Operation Stand, Walk, Run, which is a organization which we've developed with a mission of education, humanitarian care, teaching and training, and the elevation of orthopedic surgery in Nigeria. Encourage you to check out our website and follow our links and our YouTube links and some of the videos and some of the mission work we have done. As we all know, there are definitely a lot of growth in the field of orthopedics in Nigeria. And our goal is to help in some small way to build that and providing care, exchanging ideas, bringing technologies, and again, educating, and that's where these lectures are coming to play. We'll get started on our topic today. I'd like to introduce our moderator, who's Dr. Oluwaseun Kimbo. He's an adult reconstruction specialist from Kansas, and he'll be guiding us through this lecture. Dr. Aham Onyike and Dr. Julius Oni, who are also adult reconstruction specialists based in Washington, D.C. and Baltimore, will be on our panel and helping facilitate the conversation afterwards. And without any further ado, I'd like to introduce our distinguished speaker. We were just chatting today that myself and the speaker have known ourselves from 18 years now, so it's a long time in the path of in orthopedics and getting to this point. But I want to welcome Dr. George Ozoude and thank you for your time and gracing us with your knowledge today. Our topic today is degenerative meniscus injuries of the knee, so a cutting edge sports medicine topic. Dr. Ozoude was born in Houston and raised in New York City. He has a stellar educational background, having completed his medical degree and residency training in orthopedics at the University of Illinois Chicago Medical School. After that training, he went on to return to Houston to complete his fellowship in sports medicine from the Baylor College of Medicine and the University of Texas Health Science Center at Houston, UT Health Medical School. He also has a proven track record within sports medicine, having served an assistant team physician to numerous high school, college, and professional sports teams, including the Houston Texans, the Houston Rockets, Houston Astros, the Houston Dynamo, the University of Houston Cougars, the St. Thomas High School Eagles, the Humble ISD, and UCANY ISD. And I think that's just a few because I did peek at your resume, and the list of sports teams you've covered is very extensive and very impressive. Thank you, George, for blessing us with your presence, and looking forward to this lecture.
Absolutely. Thank you guys for having me. It's my pleasure to present this topic to everyone today. And I hope it helps. I hope it leaves some ideas, answers some questions, and provokes some thought-provoking conversation. So I'm going to share screen if we're ready for that part.
Yes, we are. Okay, I think we're good now.
Okay, we're good now?
Yes.
We're going to go large here on our presenter, on our slideshow mode, and then we'll get started. Okay. So our talk today is on degenerative meniscus tears of the knee. I have no conflicts of interest to disclose. So the goals for the next 30 minutes or so are to characterize meniscus anatomy and pathology, describe the presentation and evaluation of degenerative meniscus lesions, review the current consensus on treatment outcomes, and highlight some current treatment options. This is known to be somewhat of a controversial topic in the orthopedic community. However, I personally see this as a fairly straightforward condition regarding decision-making in my mind as a provider, since there are many proven tools in our toolbox for treating these injuries. And in fact, I really like this topic because it allows for both the science of evidence-based medicine to function alongside the shared decision-making process and personalized treatment planning with patients. So the meniscus is a semicircular shaped structure in the knee that serves many functions, and it's essential for joint stability, shock absorption, distribution of contact forces, joint lubrication, and proprioception. It's one of the most commonly treated conditions in an orthopedic practice. It can present as acute injuries in younger active patients or chronic dysfunction in older patients, also known as the degenerative meniscus lesion, DML. The impact of these degenerative tears is high as it correlates with chronic pain, decreased walking endurance, and decreased balance. I consider it as part of the same spectrum of degenerative joint disease as primary osteoarthritis, as it shares many of the common same risk factors. So the normal anatomy of the meniscus is seen here. It's a fibrocartilaginous structure that is C-shaped medially to the left of your screen and O-shaped laterally to the right of your screen. The substance of the meniscus is highly complex and organized, consisting of circumferential longitudinal fibers that absorb hoop stresses of that specific compartment. And this helps distribute force evenly across the articular cartilage of the femur and the tibia, protecting them from excessive surface loading. There are also radially oriented fibers and randomly oriented fibers that provide the scaffold for the chondrocyte cells and the extracellular matrix of the meniscus. Each meniscus has an anterior and posterior root attachment, which are critical for the normal functioning of the circumferential fibers. Grossly, there's a medial and lateral compartment anatomy that has some key differences. Here you see a sagittal view of the medial compartment as it demonstrates its more concave, constrained relationship between the femur, the medial meniscus, and the proximal tibia. While laterally, the compartment has a convex and a less constrained articulation. So the lateral meniscus is more mobile compared to the medial meniscus, and interruption of its function has a bigger impact on the distribution of the joint reactive forces as a result. And the blood supply of the meniscus is very important. It comes from the inferior genicular branches of the popliteal artery. At the level of the meniscus tissue, it forms a perimeniscal plexus of vessels at the capsular attachment and the outer rim, which is important for possibly understanding the pathogenesis of the DML, as well as the determining viable treatment options when it comes to possible surgical repair. It's well understood that the inner 2/3 of the meniscus is essentially avascular and aneural in adults. This red-white and white-white zone are believed to be the anatomic starting point of the degeneration process that occurs in degenerative meniscus lesions. And so that nicely segues into our pathology. With DML, we know that there's an intrasubstance disorganization of the fibers, cells, and the extracellular matrix. This degeneration starts centrally and progresses to the superior, inferior, and capsular surfaces of the meniscus. And this eventually leads to unstable tissue interface with the rest of the compartment, mechanical dysfunction, and painful inflammatory response. And so we do not fully understand the underlying reasons for why this happens, but we suspect the same factors that are related to the development of primary osteoarthritis. Advancing age is a known risk factor for having evidence of a meniscus degeneration on MR studies, and this can be seen in both symptomatic or asymptomatic patients. Weight is commonly considered a risk factor, along with repetitive use from decades of work, hobby, or sport. With the amount of general deconditioning and muscular tightness that I usually see in my practice, even in young age groups, I also suspect that there could be some risk contribution from core imbalance and other global musculoskeletal dysfunction. When tears do progress, they may take the form in a combination of many different patterns, which we'll also show later with MRI examples. These degenerative lesions are usually seen in all of these patterns, except for the longitudinal pattern here, which is usually typical of and more characteristic of an acute traumatic tear in a younger patient. So a very difficult sub-pattern is this root tear pattern, and it's very difficult to treat these degenerative root tears and root equivalent tears. As mentioned before, these tears directly impact the functioning of the all-important circumferential fibers. Without a without a competent root attachment, these tears lead to the majority of the meniscus extrusion presentations that we see on MRI. And this is where the joint forces displace the tissue of the meniscus from its normal anatomic position. And this is painful and uncomfortable in and of itself, but loss of the cushioning effect of the meniscus is just as significant in the long-term joint wear. And so how do these degenerative lesions present? Well, patients usually complain of a slowly developing pain and dysfunction without a specific traumatic event. They can get episodic flare-ups as the tear can become unstable at times. They can also describe mechanical symptoms, which I put in quotes because it is still a very broad definition that has not reached consensus even within the orthopedic community. This catch-all phrase includes painful locking, catching, or buckling sensation of the joint. And it's important to note that many degenerative lesions exist within the meniscus without symptoms in older patients. And this can be the setup for that acute on chronic, for the acute on chronic subset, tear subset, where there is a specific low energy traumatic event that triggers the onset of the classic symptoms. And I call it a subset of degenerative lesions because I wouldn't classify it or approach it the same way as an acute tear from an injury in a younger patient or athlete. I would still treat these as degenerative lesions. So even though the classic presentation is very common, I think it's still important to probe deeper and get a full history, as this information will be crucial when it comes to time for collective decision-making and managing the expectations of the patient. So I ask about a detailed work history, including repetitive labor-intense duties. I ask about hobbies that they enjoy. I get a sense of their lifestyle, whether they're overly active or overly sedentary. All of that is important information to gather for that decision-making process. And so many middle-aged and even older patients are now engaging in fitness trends and recreational exercise, which can be a great thing. But I like to ask about, if there's been any recent ramp up in their level of activities that puts them at risk for the acute on chronic tear subset. This is like that too much too soon effect, which can lead to injury. When it comes to physical exam, it's pretty standard, straightforward. You assess their weight, their BMI, you look at their core strength and their lower extremity alignment. Sometimes you may or may not see an effusion. There's specific tests for the meniscus, such as the joint line tenderness, which can be a bit non-specific, but then there's more specific provocative tests, such as, McMurray's test or Apley's test. You always want to check for ligamentous stability and range of motion. This is typically normal when it's an isolated degenerative meniscus tear. I like to go a little deeper with the physical exam. I like to really, drill down into their core stability and their flexibility. So I have them do several tests that give me a good idea of where they stand. And like I said, many patients, even younger patients, present with core imbalances and flexibility imbalances that I believe put them at risk for abnormal joint reactive forces and degenerative lesion progression. So I like to test their single leg balance, their single leg squat. I like to put them on the exam table, see how they look and, respond when I ask them to do a sit-up. I like to test their flexibility, the Thomas test, Eli test. These are all tests for lower extremity and core flexibility and tells me a lot about their overall global musculoskeletal status. So all of that has to just be, kept in mind with other potential diagnoses that you have to consider, right? So it could be osteoarthritis, there could be loose bodies, plica syndrome, or pathologic mass. And that's why and where imaging becomes such an important role. X-rays are considered a first-line diagnostic imaging tool that all patients should get. Here we see a normal X-ray with normal joint space compared to an arthritic X-ray, end stage here. This could be a 50-year-old male who's active. Either one of these X-rays, could represent that gentleman's knee, and he can come in complaining of meniscus symptoms, and degenerative meniscus can be present in either of these X-rays. And so that's why it's important to get these initial X-rays on the initial presentation. So fairly quick test and cheap test to obtain. Higher level testing with MRI, 86 to 95% accuracy. So it's a very important test to get. It can really, detect meniscal injuries, but it's also important for assessing other type of injuries, such as subchondral bone injuries, chondral loose bodies, injured ligaments, and synovial tissue disease. Ooh. So I wanted to jump into some different types of injuries that present on MRI, specifically for degenerative meniscal tears. So here we see a sagittal view of the knee, and you can see the meniscus anteriorly. It's normal, has its full triangular presentation. Here we see degenerative tear that starts in the mid substance and, like I mentioned before, extends out into the inferior substance and becomes potentially symptomatic unstable tear. Here are a sagittal view and a coronal view showing a meniscus root tear. And whenever I see this on an MRI, I just grab a seat in the clinic room and get ready for a long conversation, because these are one of the more challenging degenerative meniscus injuries to treat. So here on the coronal view, we see the posterior horn on the medial side with a disruption right at the posterior horn and the corresponding fragment of the root attachment. On the sagittal, we see what's called the ghost sign. It's the absence of the normal triangular shape of the meniscus that would be represented there on the posterior horn. There's some subchondral edema and loss of cartilage, articular cartilage as well. And that usually also correlates and corresponds with this extrusion that we see. So here on the medial side, we see this meniscus, medial meniscus, in an abnormal position compared to the lateral meniscus, which is in its normal anatomic position. It's extruded, and then there's associated articular cartilage loss and subchondral bone edema in this compartment as well. Again, these are usually have to have long conversation and a very thorough decision-making process, shared decision-making process for these type of lesions with patients. Here on the coronal, we see the medial meniscus with a horizontal tear, but it has a displaced inferior fragment that's actually wedged in the tibial gutter. And this is likely causing some displacement, again, some extrusion of that medial meniscus. And it is also possible that this horizontal pattern extends into the root, causing some loss of the circumferential fiber function. Here's a sagittal with the anterior degenerative meniscus extending into the surface of the meniscal articulation. And then so that leads us to kind of what do we do about these lesions? Well, the 30,000-foot view in general is to, have these overall goals of relieving symptoms, decreasing immobility, limiting the recurrence of those symptoms, and decreasing the risk of progression of symptomatic osteoarthritis. And I will reemphasize again that shared decision-making, I think, is super important in this type of injury. Even though we rely heavily on high-level evidence, I still think it's important to remember every patient is going to have a different set of circumstances, expectations, and goals. And so that has to be considered in the final decision process and treatment process. But there are plenty of guidelines and decision tree algorithms that are available from different institutions. They're all based on high quality level 1 randomized controlled trials that essentially agree and tell us that immediate surgical intervention is not necessary and it's not more beneficial long-term compared to a non-operative conservative treatment approach. Here in this study from 2017, there are several randomized controlled trials that were evaluated and a consensus statement was achieved. And this was across several different international institutions. You can see here on the results that all of the comparisons from arthroscopic meniscectomy to conservative treatment showed equivalent results. And we can look at some of those studies in particular. Probably the most famous of the study is the Mosley study that was done here in Houston. 180 patients. This was published in New England Journal of Medicine in 2002 out of the VA. There's a 2-year follow-up, and it showed no improvement in pain outcomes when comparing arthroscopic meniscectomy to a sham surgery. And then later, around 2013, a lot of studies were performed that reconfirmed this finding. This is a study also out of the New England Journal of Medicine, 146 patients, 1-year follow-up, found no difference between meniscectomy and sham surgery. It was a broader population, more than just the VA and male patients. This kind of had a broader sample size, but again, it showed no significant improvement in either, it showed no difference, but a specific particular finding was that it had significant improvement in both arms, whether you had meniscectomy, sham surgery, or conservative treatment. And then this study in 2013, again, 108 patients, 2-year follow-up showed improvement in Lysholm scores at 3 months in the operative group, but otherwise for long-term outcomes, there were no difference when compared to non-operative treatment. And so there are exceptions that are uniformly agreed on for the most part, being knees that present with statically locked knee presentations, as well as persistent, recurrent, debilitating locking. In these situations, immediate surgery is considered an acceptable decision. Non-operative treatment can be attempted for 3 months at minimum otherwise, and outcomes when compared to knee scope and partial meniscectomy have been found to be equal. And so while this is great news, it's also important to note that some studies do show that there is a crossover conversion of about 30% of patients who fail non-operative treatment and they end up having to have that knee scope done. The good thing though is that these patients, they go on to have the same outcomes as patients who are either in the successful non-op group or who had early surgery for these conditions. So I think this is a really, this kind of settles a lot of the controversy of kind of what to do and what matters. All of them do good, no matter what treatment options you choose. It's just a matter of, if it's early treatment or late treatment, they all have good outcomes. And I think that is an important, reality, and it helps with guiding patients and having discussions with them about their treatment options. We have plenty of tools in our toolbox to help them out. So what are these non-operative treatment options? So there's lifestyle modifications, there's physical therapy. I think these are kind of just broad terms that I hear and read in different sources. I think there's probably some benefit to kind of getting a little bit more detailed with that. With lifestyle modifications, I really see just the recommendation for weight loss, right? But I think that that's not a switch that patients can just turn on. I think they need a lot more guidance lot more help. And we're orthopods, so I, lean on and outsource that to primary care doctors. There are now lifestyle medicine fellowship trained doctors that can help with specific challenges that patients have with weight loss. I think physical therapy is also kind of an ambiguous thing. I think it's well understood that physical therapy and medical exercise helps, but there's really not a study that shows which particular exercise is beneficial. So I think it's also important to really kind of have a good therapist to go over what I think is the big contributors to musculoskeletal global imbalance, and that's core strength. I think a lot of the physical therapy exercises should be focused on that, should be focused on flexibility and proprioception. I think activity modification is a big factor as well, big option for an opportunity to help these patients out, whether it's their occupation or their sport or their hobby. There's a lot that we can kind of, a lot of guidance we can give them along these lines to help them either decrease temporarily their symptoms or get more long-term beneficial effects. There's pharmaceutical management, and I'll kind of speed up into that. And studies show these are good for temporary relief. This can either be oral anti-inflammatories, injections, they can be topicals. In my early career, which is still, only 8 years deep, I would give out injections fairly, ubiquitously, but I've slowed down on that. I think what happens, the challenges of these pharmaceutical interventions is that they become chronic pain managements. And patients really just start relying on them instead of focusing on the rest of the non-operative treatment options. And I think that presents a problem in the long term because there's still ongoing degradation of the joint from the underlying factors. And that's kind of, evolving along with their declining health as they get older, typically. It's not the case for everyone. So I think there's a little bit of a risk in just injecting patients every 3 to 4 months while their arthritis or their meniscal degeneration gets worse. It puts them in a slightly catch-22 when they get to a certain age physiologically, and their surgery risk goes up. And maybe some of the total joint surgeons on the panel here can speak to those challenges. But I definitely have had patients that get up into their 80s and their health declines, and now their pain management is no longer working, and their meniscus tears or their arthritis is significant, and it presents significant challenges of managing those patients at that point. But some temporary relief for extreme pain and discomfort, I think, is appropriate indication for using these modalities. Bracing has a compression and proprioception effect, maybe more placebo more than anything. So I do use them when patients request, but I do tell them that the problem still persists. It's not necessarily changing the underlying natural history. Orthobiologics is the hot topic in general. I think the outcomes and evidence is limited regarding chronic degenerative diseases. I think it's still evolving. I think some specific challenges lie in the healthcare economics, as some of these treatments are very expensive and not covered by insurances. So this can present big challenges. I think the future is still a question mark about how this helps patients with degenerative meniscus tears. On the operative side, we have plenty of tools in our toolbox. Again, we have arthroscopic debridement, which is a fairly safe, straightforward 15 to 20 minute procedure with low complication rates. We'll see later, there's some healthcare economic considerations that we need to keep in mind, as we treat patients with degenerative meniscal tears. As far as repair techniques, there are techniques for repairing root tears. These can be challenging tears to get to heal, as they're degenerative and the underlying process still remains the same. A big challenge is repair alone doesn't necessarily fix the extrusion. And sometimes we need to add a capsular release to fully get that anatomic fixation and positioning of the meniscus. There are techniques that have evolved for fixing more standard tears. These are your arthroscopic techniques that include also some potential hybrid techniques with microfracture and orthobiologics for added benefit to improve tissue healing of the torn meniscus. There's also trephination along the same line of improving the biologic environment of the knee joint to get some of these tears to heal. Once you kind of do these hybrid techniques where you trim part of the tear and then repair part of the stabilized and healthy aspects. Postoperatively, the rehab goes that with meniscectomies, we have self-selected weight bearing and optional brace or crutch use. And this is usually for about 2 months with daily physical therapy with 1 to 2 formal sessions of therapy with a therapist per week. In repairs, it's a slightly longer rehab protocol. And that first month is a little bit more protected with weight bearing in a brace from 0 to 90 degrees. Usually it takes about 4 to 6 months of recovery before they're back to their normal activities. So kind of final perspectives. Overall, we do about 700,000 of these knee scopes per year in the United States. And I think with the evidence that we've uncovered, it's becoming clear that some of these are unnecessary and we're doing too much. And so even though the complications of meniscectomy and knee arthroscopy are low, I think it's still unnecessary. Surgery is too high of a risk, when we're considering each patient individually. In my practice, I definitely lean towards non-operative treatment for degenerative meniscal tears, but still I have that caveat that every patient is different. And so if I have a patient who, is, specifically has a root tear, and I know those root tears do worse compared to other types of tear patterns. And I've gone through all the risks and benefits, all the outcomes, and they want to go ahead and try to get that tissue to repair, just to try to protect, get that tissue to heal to try to protect the knee from further progression of their osteoarthritis. I will consider, a repair for that patient. Otherwise, I do lean towards non-operative treatment for the vast majority of them, with the understanding that if they fail, they can still undergo a procedure that's safe, that's quick. It really doesn't change my surgery that I do if I were to do it today or 6 months down the line. So it really is a shared decision-making process that gets the patient involved in that decision, that gets their expectations kind of more in line. And I feel that kind of makes for a better outcome all around. So again, personalized treatment plans, all the treatment options have good outcomes, even with crossover. I think one specific thing to really reemphasize is that lifestyle modifications and physical therapy are, in my opinion, the foundation, whether you do surgery or not. I think the underlying problem is there, and that's where these degenerative meniscus injuries kind of started to begin with. And I think without addressing those, patients can still have symptoms, whether they undergo surgery or not. So I think a lot of emphasis should be placed on the lifestyle modifications, whether they have surgery or not. And that's the end there. So thank you for your time, and I can open it up for questions from the panel or from the audience.
Thanks, Dr. Ozoude. That was an excellent lecture and excellent review of that topic. I definitely picked up a lot of different things that I haven't picked up in a while as a joint replacement surgeon myself, in terms of how to pay attention to the meniscal tear. So thanks so much for that. I forgot to mention earlier that Dr. Ozoude is the medical director and leading orthopedic surgeon in the Movement Orthopedic Institute in Houston, Texas. So anybody who's having any meniscal tears, please, in Houston, Texas, take time to refer to Dr. Ozoude there. I'll hand over to Dr. Kimbo, who will be moderating our discussion session and questions.
Yeah, thanks, Didi, and thanks, George, for that lecture. It was truly very informational. At this point, anyone that has questions in the audience can just drop your questions in the chat box, and we will entertain them and answer them. But quick thing for you, a few questions for you, George. Does age matter in you're deciding which patients will ultimately get non-surgical versus surgical management?
Yes, it has an impact. I wouldn't say that it is a hard and fast rule as to who gets surgery or not. I think there's chronologic age and then there's physiologic age. There's definitely 50 and 60-year-olds who physiologically behave like someone who's under 40. And even though a lot of the algorithms will cite kind of 35 to 40 as that cutoff, I think there's room for interpretation when it comes to individualized, personalized treatment. But in general, that's about the cutoff where we say, a degenerative meniscus tear is usually going to be what presents in someone who's over 40. And therefore, this algorithm, this, focus on non-operative treatment kind of becomes the emphasis. Whereas below 40, we're looking more at acute tears, and that has been accepted universally to be something that we treat surgically. I also think not just age matters, I think the degree of their arthritic progression matters. So if we're talking about a 50-year-old with end-stage osteoarthritis from whatever reason, primary, secondary, then this has way more weight than the chronologic age. They can be 45 or 50 with grade 4 arthritis. They're not going to do well with surgery for their meniscus tear, right? And so I think it's still a multifactorial consideration, even though we do pay attention to age.
Okay. Another question for you. So we'd say grades 2, grade 3, would you tend to scope those in young patients that are very athletic versus focus on non-surgical management versus referring to someone like Dr. Nike or Dr. Mi for surgical intervention? Like a sort of background to that, in our literature, joints-wise, it kind of sounds like if you have some form of degenerative changes in your knee, you're better off with non-op management till you can get surgery. And surgery being like a joint replacement. How does that factor in your literature and your experience?
So in my experience, for someone with low-grade osteoarthritis at a younger age, I feel like they have more opportunity than any other age group to modify their lifestyle, modify their risk factors for progression to osteoarthritis. So I would definitely lean toward non-operative treatment for them. I think that's the first line. I think there's a lot that they can do not only to avoid a knee scope, but to avoid a total joint replacement. For me, what makes a bigger difference are those exceptions where they have the locking, the catching, and there are some studies that show even with those mechanical symptoms, they can still do well without surgery. They can do well non-operatively. But if someone that age has severe locking, a locked knee joint, I would lean more towards surgery. But the good thing is the majority of them do not present with those symptoms. They usually present with classic symptoms, the achiness, some mechanical catching. These patients are good candidates for physical therapy. And if they don't get better, we're going to know way before they ever need a knee replacement. We're going to know in 3 to 6 months whether they want to move forward with a safe surgery or not.
Okay. And do you think the locking symptoms, mechanical symptoms, do you think they're from like arthritis or meniscal tears? I think in the past, it was usually thought to be from like meniscal tears, but at least in our literature now, there's evidence saying it's more from the arthritic changes than meniscal tears.
I would agree with the statement that it's not it's not 100% known that it's coming from the meniscus. I agree with that. I think we're still learning about, different sources of locking. When we were in training, I think we're all kind of in the same, training group era. I think it was really, mechanical symptoms come from either meniscus or loose body. But with the newer literature showing that it could be chondral lesion, right? Could be from just the overall environment from the osteoarthritic joint. I do think that has to be considered. And the evidence shows that even with some mechanical symptoms, you treat these patients with low-grade arthritis with non-operative treatment, they do well, even though they present with mechanical symptoms. So I would agree with that. I would agree with we have to consider things outside of the meniscus when someone presents with mechanical symptoms.
So I don't monopolize Judge's time. Does anyone else have other questions? If not, I'll keep firing with questions.
Yeah, Dr. Ozoude, great talk. Sorry I showed up a little late, but I caught the end of your presentation there. And just a quick question, for that 60-year-old that is physiologically acting like a 40-year-old, and that you've indicated for an arthroscopy and meniscectomy, how are you counseling them with regards to their risk of further surgery in the future, or what are you saying to them at that point?
Yeah, this is that, personalized treatment, where it really becomes important. Number one, I determine if they're having severe mechanical symptoms, because I explain to them that I can't make your general ache and pain better. If you have mechanical symptoms, I can make that better with a knee scope. Your knee ache and pain and swelling and potential stiffness, that can be coming either from your meniscus or from your early arthritis or both. And the knee scope cannot fix the arthritis process. And so I'm having that specific conversation. I really want them to understand that, because if they don't, they will come out of the surgery 2 months later into their rehab, and they will be confused as to why their knee still hurts. They'll be unsatisfied with that outcome. And so if patients don't really clearly demonstrate to me that they understand that, I lean even more towards non-operative treatment. To say, we need some physical therapy. Let's see if that ache can get better. And if they understand that it is, the mechanical symptoms is the main problem, I always have them grade, like what's the bigger issue? Is it the locking, if they have locking, or is it the ache? And I use that to guide my decision. And then I even have a further conversation about, if I go in and do surgery, I'm specifically going after that locking. And it potentially may make you feel better to the point that you're happy with the surgery and the outcome. You may not be pain-free, but you'll feel satisfied that you're getting back to your higher level activities, because they're physiologically younger than just being 60. So that's the kind of conversation I have. And by the way, these conversations for degenerative joint disease for me take 30 to 45 minutes. There's a lot of unpacking and explaining to do for patients, a lot of different scenarios and pathways that I take the time to walk them through.
I was going to say, you mentioned modifying lifestyle a few times. So in the patient that Julius just talked about, the 60-year-old that's physiologically in his 40s, that's very active, what is modifying lifestyle for that person?
So for that patient, I'm looking at their musculoskeletal balance. They're having, and a lot of them they just have core instability. I think it's just the nature of kind of our society, our culture. We sit down a lot, we're sedentary. Even with the active patients, even with young active athletes, a lot of them have core instability, which you can uncover from a physical exam or from a physical therapist. And so I address those, I emphasize those. I show them from the physical exam how they have a unstable or unbalanced core. And then we talk about just kind of in general, becoming a little bit more resilient to just the day-to-day. I think that has an impact on how they perceive their knee, their functioning of their knee, their pain. If they're slightly overweight, we have that conversation as well. And so, these middle-aged patients at this age group can still be dealing with all those lifestyle factors that need to be addressed. I still think there's a lot of room for that.
Yeah, thanks. I just wanted to chime in. Well, first of all, say thanks to George for sharing what I think is a detailed, comprehensive, and evidence-based opinion and lecture this morning. And thank everybody who's here participated in this current concept lecture series. I personally find this topic very enticing to listen to, and generally one that can be frustrating in my practice. As you know, I'm an arthroplasty surgeon, so I'm very happy to see a patient that I can help convincingly with an arthritic knee. But these patients with a degenerative meniscus, my approach has evolved through the years, and I'm not sure I still have it right. I think the patients with mechanical symptoms are easy, obvious choice, but those who have pain with radiographs that are underwhelming and still have persistent symptoms can be very, very recalcitrant to treatment and very frustrating, to the point that I think I've seen some early arthroplasties, and I'm not sure that's the answer, right? So I think it's a little bit of a conundrum, and just wondering what the percentage of people that George, you see, and others on the panel see that have real mechanical symptoms, because in my experience, very few have mechanical symptoms. And so it still remains a frustrating problem as to how to get them better when they have lingering symptoms without mechanical symptoms and a clear degenerative tear.
Yeah, I agree with you, Aham. I think we don't really have a consensus on the phrase mechanical symptoms. It can mean so many different things to the physician. It can mean different things to the patient. I don't know if you guys noticed, but whenever you ask a patient what mechanical symptoms are, or if they have mechanical symptoms, they kind of look up in the air and kind of try to like think about what that means. You can see that them processing that, and then you ask about catching, specifically locking, rubbing, clicking, and they still kind of don't quite know what that is supposed to feel like. And so I don't think we have a good foundational framework of that definition, mechanical symptoms. And so in light of that, I do agree with you. I think we probably we're taking too many patients to the OR too soon with mechanical symptoms. But to me, the true locking, where they feel like they have to manipulate or maneuver their entire lower extremity in order to walk, which happens, usually when they get up from a seated position or something, or if they come in and present with a locked knee, which is super rare. But I think that's kind of the more true definition of those mechanical symptoms in patients who need immediate, earlier intervention.
Yeah,
I think.
Go ahead, Julius.
Sorry, go ahead. So I just wanted to just chime in along the lines of those same patients that I'm just describing, that Judge just eloquently gave some follow-up feedback on. I think there's like a subset of patients that do have extra articular sources of knee pain that sometimes get these early MRIs, and we find incidental findings of degenerative, meniscal tears or some mild degeneration. They usually have underwhelming radiographs. They still have significant persistent pain. But when you really drill down with physical examination, you realize that maybe they have pes-anserine bursitis, maybe they have IT band tendonitis. But but that really requires significant listening to the patient, actually doing a detailed physical examination, which we all know now in these days of trying to see 40, 50 patients, it becomes less feasible to do. But I more and more, I'm realizing that when you actually drill down, I'm seeing more and more of this extra articular patients who are coming in with their MRIs completely locked in on their meniscal tears, but then you diagnose them with this other sources of extra-articular symptoms and other etiologies besides what they're obviously coming with. And then you send them to physical therapy. And to George's point earlier, they come back 6 weeks later, 6 months later, saying everything is completely resolved because now they have good quad strength. Their pes anserine bursitis is mostly resolved. Their IT tendonitis is mostly resolved. And I just wanted to kind of re-emphasize or reiterate the importance of actually going back to the fundamentals and actually doing that physical exam and trying to drill down to what really is the problem. Thank you.
I totally agree. I think if we had enough time, we would really see how many patients have these core musculoskeletal imbalances that put them at risk for these tendonitis. These are overuse tendonitis injuries. That in combination with their repetitive day-to-day, whether it's work, hobby, sport, they're going to get these overuse injuries that are right around the joint line, and they mimic, these meniscus injuries. So, and then, MRI studies show that you get degenerative tears even without symptoms, just as you age, just like the lumbar spine and disc degeneration. It's the same, or similar. It's likely the similar process. So,
yeah, I also would reiterate the point of a thorough, detailed physical exam when the symptoms appear disproportionate to expectations. And I think I've also, as an arthroplasty surgeon, seen patients who come to me for a second opinion with a well-done total knee that's still painful. And very often it starts with that picture of, well, there was a scope, there was injections, there was HA and corticosteroids, and eventually a total knee on an X-ray that was, again, underwhelming, and there's still pain. And I've seen some where it was extra-articular, and I've seen some where it appears intra-articular, but it's still not clear why the proportion of pain was that high. So I think it does reiterate the point that a good convincing physical exam is imperative before accepting that the meniscus, degenerative or otherwise, is the singular culprit.
Well, we have a couple of questions from the audience. The first one has to do with secondary gain. So in patients, in workman's comp patients, oftentimes they will focus on the MRI report or deny the chronic condition. Any thoughts on the management differences in patients that may have secondary gain?
Yeah, that's definitely a challenging population. I think that, let's see, patients' tears particularly difficult as they frequently minimize or deny chronic condition. Focus on the MRI report.
I think the question is, how do you manage them differently from your typical? Or do you manage them differently from your typical?
I try to manage everyone the same, just on the foundational level. I try to almost ignore the fact that they are, presenting from a workers' compensation standpoint. Obviously, there are some considerations there we have to take into account, but I definitely try to approach them the same way. It's, thorough physical exam, try to uncover their symptoms. You sometimes do deal with patients who are trying to, have secondary gain. When I encounter that, I really double down on, number one, not, proceeding to surgery too soon. I'm even trying harder with physical therapy first. I'm even having sometimes more in-depth conversations about kind of why they're potentially maybe looking for some secondary gain, and explaining to them how objectively everything I see on, my assessment doesn't match with what they're, complaining of, right? And try to come to some common ground, some resolution to kind of get past that impasse. And that's kind of how I approach those patients.
Okay. There's another question, and the other question is, in a young patient in the late 20s with patella alter in one knee and mild arthritis on the same knee, with majorly intermittent pain as a main concern during sporting activities, is surgery the best option?
No, that's even more clear indication for thorough physical exam and non-operative treatment. I think patellofemoral mechanisms and conditions really underscore a core imbalance, some kind of imbalance, flexibility imbalance, that we see in young age groups, teenager, high schoolers, they have patellofemoral issues. And I think I'll double down on those patients. There's not very much we can do with the arthroscope, or probably even, well, definitely with the arthroscope, there's not much we can do that's going to help those patients more than physical therapy.
Okay.
Joe, you have definitely highlighted the importance of therapy and, excellent highlighting in terms of, core imbalance and proprioception and things like that. And, I think as surgeons, we probably don't focus on those conversations enough with patients. Most patients, when they come to see the orthopedic surgeon, are automatically thinking they want surgery or they're looking for that scope. When having these conversations, and we've talked about the difficulty or the nuances and kind of get patients on the same page, what percentage of your patients would you say are you able to kind of, get them to the point where, if you can talk about that, get them to the point where they understand, hey, look, okay, my problem is not necessarily this meniscus tear that I'm focused on and highlighted on the report. It is my core imbalance, is my deconditioning of my knee. And where do you then decide? So what percentage of patients are you able to get to therapy? And then at what point in time do you either decide, hey, you know what, we're not meeting, we're not on the same page, maybe have a second opinion, versus, okay, just go ahead and do the scope and hope everything works out well?
Yeah, unfortunately, it's a low percentage. I think the awareness, is not there. It's something where you're trying to help the patient catch up on and educate them on the association of something that's not necessarily directly involving their knee, but how it's actually impacting their knee function. And I think the awareness is a challenge, and essentially getting patients to buy into it and almost change their habit, because this is something that has evolved over their lifetime. And so the habit of not keeping your core in balance, or keeping your muscles flexible, is something that you're trying to reverse, and so that's the challenge. And when they do buy in, you see the effect of it, and they come back, and you really appreciate that they appreciate it, but I'd say probably 15%, maybe 10%, especially as they get into the middle age and older. They're stuck in the ways that they've always known their whole life, right? And so that's one of the bigger challenges. And then for those patients, it's still a matter of doubling down on the therapy, especially if I see they haven't really made progress. And if they push for surgery, I emphasize even more that they're likely not going to do much better in light of, the lack of progress that they've made with the non-operative treatment, and so I really emphasize that, for those patients. If they, again, have specific circumstances that kind of warrant a knee scope after 3 to 6 months, then again, it's a safe enough procedure to move forward with it, to see if that helps them. But I never really kind of move away from the core imbalance lecture, the core imbalance angle that, I'm constantly talking to them about.
Great, thanks. Yeah, mute Olin.
So I think we've talked about this with the assumption of tibiofemoral arthritis and meniscal tears. In patients that have patellofemoral arthritis, does that actually play into your decision-making or not? And if it does, when does it play into your decision-making?
So there are certain circumstances that I do see mechanical symptoms in the patellofemoral disease process, and that's with the plica syndrome. It's rare that it ever progresses to the point that, needs surgery, but they can develop a thick enough plica that they get mechanical, discomfort. And in those patients, I think that's a fairly underdiagnosed condition. I think those patients can get better. But otherwise, I think it's all imbalance that, again, needs to be addressed with non-surgical techniques. And so that's kind of a unique little caveat for patellofemoral disease.
And let's say you have a patient with degenerative meniscal tears, mild arthritis, maybe grade 2 preoperatively. You go into the surgery, you've done all the physical therapy, non-surgical things, you get into the OR, you scope the knee, it's more like grade 3, maybe some areas of grade 4. In those patients, do you consider knee replacement afterwards? And if so, how long do you wait after the scope?
So I at least allow them to recover from the rehab period. If it's a meniscectomy that we did at that sitting, then I'm waiting at least 2 months. That's the typical time that I would see someone fully recover from the meniscus. If they still have pain, I would go back to non-operative treatment. I use that as a tool to say, look, we did this knee scope. We knew we had some other issues and risk factors. I think we need to double down on those risk factors. Because honestly, those are the same risk factors that put them at risk for challenging outcome following knee replacement, right? Those things need to be addressed one way or another. So, and at that point, it's really their function and their pain, the standard indications for a total knee. If they have severe pain, if they progress to the point where they have severe pain and dysfunction that's interrupting their life, then, knee replacement can happen within about 6 months of a surgery if it's that severe. I usually don't see it that severe though.
Okay. Another question from the audience. So if a 60-year-old presents with root avulsion, but the MRI is 6 months old, would you consider repeat MRI prior to arthroscopy? And this is referring primarily to patients who may develop a sunk lesion, and then arthroscopy is no longer useful to this particular patient.
Yeah, that's a really, like I said, one of the most challenging situations are those root tears. A 6-month-old MRI in that patient is probably going to be sufficient. I don't think there's going to be much change that's going to be seen. You could get that MRI to kind of assess if the bone marrow injury is progressed or if it, is starting to set on. I think I'm having that conversation whether it's a fresh MRI or not. I'm having that conversation about the fact that this is essentially a non-functional meniscus, and you're at risk for developing these symptoms following a knee scope. And I think that's really the key. It's that communication about their risks going into that surgery or going into any treatment option.
And you've mentioned core imbalance quite a bit. For those of us that don't work out that often or are not workout aficionados, how do we detect if a patient has core imbalance on physical exam?
So I like to do a certain tests in the office. And there's certain tests you can do, in the office, you're limited, and there's other tests that like a physical therapist can really do. But I like single leg type of physical examination. I think this is a great question. This is like practical stuff that can be taken away and used on a day-to-day basis. So single leg balance, if you show them that they literally cannot keep their balance, that's a core instability issue. And they have this aha moment. Then I have them try to do a single leg squat, also called a pistol squat. They'll usually have some instability in their knee. What you typically want to see is that their knee stays quiet, meaning it doesn't shift in internal and external rotation or abduction and adduction. It should just stay with the patella pointed straight. They usually fail that test. And I, again, say, all right, that's some more core instability. I have them sit in a chair, sit to the edge of the chair with their knee and their thigh and their leg at 90 degrees. And I'll ask them to try to rise from the chair without momentum swinging their upper body forward and without using their hands to push off on the chair. You literally have to try to rise straight up. And these are, honestly, these are tests that just make it hard, that are hard for anyone to do. But it just serves as a point where you can really highlight to them and make them see like, oh, something's not balanced here. I wasn't, I have this deficit, it proves it to them. There are times there are stools, small stepping stools. I'll have them step up and down off of that very slowly. And if they can, again, do that in a controlled fashion without a lot of movement in that knee and that hip knee angle, then, otherwise that shows me that they have some core instability. And then all the flexibility tests, I show them that, kind of show them the difference. If they have pain in the ipsilateral limb, obviously that's what they're presenting for. I use the contralateral limb, their good leg, if it's asymptomatic. And so you can, show them that it's both sides. It's a global problem, and so those are some ways that I uncover it to them in the exam room.
Yeah, that's great. Definitely don't check core imbalance, and we'll be adding that to my physical exam regimen.
Yeah, absolutely. That's great. And I think that's excellent in terms of just coming back to that point of how the basics, again, physical examination, history in dealing with all conditions, but specifically these conditions are really important. And then I think, the greatest, what I'm taking away again is having those conversations with patients, especially in this particular topic, very nuanced. It's not just, okay, meniscus tear, scope, but, a whole, taking the time to really have these longer conversations. And like I said, you pull up that chair and this is going to be a long one. The bone-on-bone arthritis, that's easy. The meniscus, acute meniscus in an athlete is easy, but this is going to take some time. So really appreciate all the questions, all the conversations. Thank you so much for your insight and expert opinion on this, George. It was really fascinating. I hope everybody's taken a lot from it. I know I definitely have. I'll leave it to Dr. Kimbo to wrap up our session, and Dr. Onyike, if there are any announcements that we have as we're coming to the end of our session today.
Yeah, thanks a lot, Judge. That was truly informational, like Didi said, and definitely picked up things that will be incorporated into our practice. If there's one thing you can leave us with before we turn it over to Dr. Onyike, what would that be in a nutshell as to how to manage patients with degenerative meniscal tears going forward?
Man, there's so many things. I think what Didi just said is super important. You're gonna have to sit down and just take time with these patients, or else the outcome, they just won't understand what to expect. And it's just not gonna meet their expectations. And if you just sit down and take the time with them, that'll already put you in a best position to succeed in their eyes, because I think they understand at that point that they have a very complex condition, and you understand that, and that's why you're sitting down and taking 20, 30, 45 minutes to walk them through that process. You're also taking that time to do that thorough exam. So I think that's the big takeaway. I think he said he's...
Yeah, I was definitely say thank you to George for an excellent lecture and leading subsequent conversations and addressing numerous questions. Also to Olu Hakimbo for hosting this and guiding it and doing an excellent job moderating. To the panelists, Didi and Julius Oni, I'm sorry. I'll say thank you very much as well. All of us are part of Operation Stand Walk Run, and we also consider everyone who's here today as part of the family. Essentially, it's a foundation that we've established, recognizing an opportunity to take some of our experiences, connections, contacts, and knowledge of orthopedics in collaboration with our colleagues in Nigeria, and work together to contribute to closing the gap, to addressing some deficits, and in that process, hopefully make an impact in elevating the level of orthopedic surgery in Nigeria. In that process, we've recognized Zoom and webinars or lecture series such as this one as an opportunity to do just that, to find and identify interesting topics and have conversations and lectures like this. So this is the second of many. We anticipate doing this regularly, and we invite everybody's participation to come back and be part of this going forward. We also welcome your participation in numerous other endeavors that Operation Stand Walk Run has started to undergo. That includes an annual surgical trip to Nigeria. You can follow us, get in touch with us through our website or social media pages. Operation Stand Walk Run, we're the only one named that, easy to find, and get in touch and we can loop you in when those things are coming up. Thanks again for your participation today, and we look forward to your continued interest in what we're doing and support. Have a good rest of the day and a good weekend. Thank you.
Thank you.